My name is Nicholas Verne, and as your new ANMS president, I'd like to welcome you to this evening's ANMS virtual symposium, which is part of our medical procedure education series. Before we get started, I'd like to remind you of our upcoming ANMS scientific and clinical annual meeting on August 11th to the 13th of this year in Austin, Texas. So this evening, our ANMS symposium is entitled Pearls of Wisdom, Physical Therapy for a Dyssynergic Defecation Patient. Our moderators this evening are Dr. Jason Baker and Dr. Nitin Ahuja. Dr. Baker is currently the Senior Manager of Clinical Training and Education for Annex Robotica. Over the last 20 years, Dr. Baker has held many prominent academic roles, including the GI Physiology Laboratory Coordinator, Deputy Director, and Associate Director of the GI Physiology Laboratory at the University of Michigan. More recently, he was also the Clinical Research Director at Atrium Health. Dr. Baker has mentored and taught hundreds of allied health professionals who perform manometric procedures. His primary scientific areas of interest include anorectal physiology, innovative manometric design, and gastrointestinal health literacy. He's presented at numerous national and international scientific meetings. Our other moderator is Dr. Nitin Ahuja, who is currently Assistant Professor of Clinical Medicine in the Division of Gastroenterology and Hepatology at the University of Pennsylvania. He serves as co-director of the Program in Neurogastroenterology and Motility, Associate Program Director of the Gastroenterology Fellowship, and Program Director of the Advanced Training Fellowship in Neurogastroenterology and Motility. And with that, I will turn this evening's program over to Dr. Baker and Dr. Ahuja.
Thank you very much, Dr. Verne, for the kind introductions. We're very excited for tonight's Pearls of Wisdom series lecture, because this is from Nitin and myself interested. This is a high regard of interest for both of us. I just want to do a little bit of housekeeping before we introduce our speaker. If you would put your questions in the Q&A box down on the bottom of the screen, we will present them to Teresa as at the end of the presentation, and going back and forth through the Q&A session. And I will turn it over to Dr. Ahuja to introduce our speaker.
Thanks, Jason. Good evening, everyone. It's my pleasure to introduce our speaker, Teresa Hoey. Teresa's worked in pelvic rehabilitation since 1997 in the Charlotte area for Carolinas Rehabilitation. She's a graduate of UNC Chapel Hill and is certified in pelvic rehabilitation and trigger point dry needling. Currently, she's the clinical specialist in pelvic health for Atrium Health. Her special interests include pelvic pain, postpartum rehabilitation, and pediatric incontinence. Over the past few years, she and her team have worked with Dr. Jason Baker and Dr. Baha Moshri to develop a comprehensive pelvic floor retraining program for dyssynergic defecation. So really excited to have her join us this evening. I'll turn it over to you, Teresa.
Thanks so much for inviting me. I really appreciate the opportunity to talk about what physical therapy can do with patients with dyssynergic defecation. So we'll go ahead and get started. So this area of interest in pelvic rehabilitation is relatively new for most of me and my team. And it sort of started with Dr. Moshri being in our area and learning from her and from courses and with practice on how to help patients in this area. So the objectives for this evening is to demonstrate the components for progressing patients who have muscle coordination deficits associated with dyssynergic defecation, and to demonstrate an understanding of the patient education that goes along with that. And also at the very end to talk about the ICD-10 codes, the diagnosis codes, as well as the billing codes that go along with treatment for dyssynergic defecation. So I'm sure everyone's familiar with the Rome 4 criteria. I think when I first saw them, I realized that these are all tests And so with physical therapy, it's really important when we get those results from the ARM test and the BET test are really important information for us to put together with our exam to get to the patient's goals for getting back to normal defecation. The defecography, I don't get to see as often the results from that, but sometimes, and that's also goes along with the other two. So this is also information that y'all are all familiar with, but when I first became aware of it and was taught also by Dr. Baker in particular about what it can do, what it shows, we take all the aspects of the test into consideration to put together with our information. So, giving us information about contractility, the coordination is especially important, and then the results of the balloon expulsion. The rectal sensation is also the last piece that can make a big difference in getting people back to fully functioning. So the subtypes I have come over time, have found to be extremely helpful for putting together information and understanding what's going to get people to their goals. So we're going to kind of go through those, and I'm going to try to put together what we do treatment-wise with each of those types. So type 1, the patient can generate an adequate pushing force, but they have paradoxical increase in their anal sphincter pressure when they're trying to relax. And then type 2, they're unable to generate an adequate pushing force, but they still have that sphincter, paradoxical sphincter contraction when they're trying to relax. And type 3, they have an adequate pushing force. They don't have the paradoxical contraction, but they either have absent or incomplete relaxation. And then type 4, they don't have a great adequate pushing force, plus they don't have great relaxation. So just going forward with that, what we do in our evaluation is, first of all, to understand what is their main complaint? Why have they sought treatment? What do they want to achieve going forward? Where are their lapses in their function? And then their functional impairments. So it's not necessarily starting with main complaint. It could be that I strain every time I try to have bowel movement. I'm unable to have complete bowel movements. There's also, of course, fecal incontinence. There's fecal staining, all that goes along with it. Now, functional impairments, we're talking more about quality of life issues there. So we want to get a handle on how is this affecting your overall daily life? Is it a lot of times that people don't want to leave home? They don't want to go out in public and socialize. They don't want to go shopping. They narrow their day down to only a few hours to go out and do things and come back home. So just to pinpoint how is this affecting their daily life, and where are we going to go? Where do we need to get to for them to be able to be satisfied with their quality of life? Fiber and water intake are basics that we find. And then specifically, how frequently are they having bowel movements? Are they having straining? Are they having incomplete bowel movements? And then how often? And then, of course, the famous Bristol stool scale that gives us a picture of how everything's coming through. Okay, so, and also if we're dealing with fecal incontinence, it's going to be the frequency of that fecal incontinence. So when we're actually examining their pelvic floor, this is a standard sort of, the beginning part is a standard pelvic floor examination. We're going to get a manual muscle test, and most of us physical therapists use something called the Laycock scale. So first we're going to assess the force of their contraction when they contract their pelvic floor. So this is going to be a rectal exam. What is the force of the contraction? How long can they hold that contraction? How many seconds? So we're looking for 10 seconds to be normal. Then how many repetitions can they do before they fatigue? And then how many quick contractions they can do in 10 seconds. And so we put those numbers together. So the force, the strongest force they would have would be a 5. Repetitions would be a 10. Endurance would be a 10. And quick contractions would be 10 contractions in 10 seconds. Then we're looking at relaxation ability. That's a little more subjective, but just what happens when they relax? Are they relaxing completely? And is it coordinated? Is their puborectalis and their external anal sphincter all working together or not? And then the lengthening ability. We're going to ask them to bear down. Now, sometimes they don't really understand what we mean by that, but we're going to ask them to bear down. And can they lengthen their pelvic floor? Really important function when we're talking about dyssynergic defecation. And then the next piece is the pelvic floor length. So this is specifically for patients who have a shortened pelvic floor. And this is more typically going to be somebody who is unable to relax at all, and also has a paradoxical contraction when they're trying to relax. And over time, their pelvic floor has become literally short, and you can no longer palpate their coccyx. There's just not enough space there. And then finally, the presence and severity and location of trigger points. And that's once again going to be somebody with a potentially painful bowel movements, or just very difficulty with having complete bowel movements and a lot of straining. So we get all that information. And then now in reality, a lot of times I don't always have time to look at those ARM results before the evaluation, but I will have time, same day of my evaluation, and put all the information together. I have not yet had like conflicting, like my examination completely differs from the ARM. I have not seen that at all. Okay, so just a comment about digital rectal exams. I kind of talked about what you want to feel, but it's important with dyssynergic defecation that you can notice the relaxation, what's going on with the external anal sphincter versus the puborectalis, and is there some perineal descent? And DRE does have a sensitivity of 75% and a specificity of 87% for identifying dyssynergia. So it is a objective exam when performed well. There was a survey study that showed that used 652 physicians and final year medical students that showed there was a lack of knowledge on this, and also that it was underutilized. And so I kind of speaking up for physical therapy, I think we get a lot of practice with this. And most of us who've done it for a while feel pretty confident about our results. So this is probably information that everyone already knows, but just to mention that biofeedback is a big portion of our treatment, not all of it, but that has been given a grade A by y'all and the European Society of Neurogastroenterology and Motility. I found this was in one of the studies I looked at. I found this was kind of helpful information for me. The conflicting results are more often come into play with people with symptom severity when they use digital maneuvers for evacuation, and when they have abnormal rectal sensation and presence of delayed colonic transit. So that does kind of give me a little bit of help with prognosis and a little bit of help with plans of care, treatments. Is it going to take longer or shorter period of time to get them to their goals? The mainstays of treatment for physical therapy are to correct that dyssynergia or incoordination between their pelvic floor and their abdominals, to improve their perception of rectal filling in patients with impaired sensation in this area. And this may be probably not new information, but treatment efficacy is 70 to 80% in RTCs, and is more effective than sham therapy, propylene glycol, or diazepam. And that efficacy is maintained for more than 2 years. So getting on more to the pearls of treatment. So this is a protocol that I use and a lot of therapists use, but not all. And it's one way to look at the baseline function. And so we're going to be looking at, can they do quick contractions? Can they do longer holds? Can they, when they hold for a whole minute, what happens? And then the rest level after testing. We're going to look at all of that and get a baseline for where. So we might see abnormalities in all these areas or just one or two. So we're going to start off by types and go through what we might need to do with treatment. I'm sorry, I do have a dog. The manual muscle test, we're looking at, we talked about what we're going to be looking at for that. So with a type 1, they're probably going to have a normal force, normal repetitions. They can hold a contraction for 10 seconds. They can do quick contractions. But when we ask them to lengthen, we're going to feel that paradoxical contraction. They may have a shortened pelvic floor. They may require manual stretching, so manual treatment as well as re-education. And then they may need to have some trigger points resolved if they're having painful bowel movements. The BET is going to be abnormal probably. The training we're going to be doing is going to be focusing on their ability to relax and lengthen their pelvic floor. And we call that down training. So we're going to focus on down training. Also, if they're really having a lot of problems with relaxation in general, sometimes these type 1 patients also cannot relax their jaw. They have jaw pain, they grind their teeth, they have neck pain, etc. And sometimes they also need to have relaxation of their diaphragm. And sometimes we have to use exercises for relaxation of the diaphragm, as well as working on the mobility of the rib cage. So this kind of starts bleeding over into more orthopedic type physical therapy. And then type 2, these patients are the ones that don't have the adequate force, and then they also have the paradoxical contraction with relaxation. The picture of the EMG on here is a baseline that is the same protocol that I've mentioned, and this would be a normal result. So the person has a low baseline, they have normal quick flicks, they're able to hold for 10 seconds, relax for 10 seconds, and then hold for a minute. The type 2 patients are going to less likely to have the shortened pelvic floor and the presence of trigger points. Probably their balloon expulsion is going to be abnormal, and we're going to be focused on coordination more than relaxation. So can they put everything together? Their abdominals function well along with their puborectalis and external anal sphincter function. Type 3, they're going to have the adequate force and won't have that shortening, so they probably won't have the painful bowel movements. They won't have the trigger points. They may or may not be able to expel the balloon, and their focus is going to be also on coordination with lots of feedback, visual and tactile feedback, so they can coordinate better. And then the type 4, this is the patient that doesn't have good strength and also can't relax. So there's not a whole lot going on with their pelvic floor. This pattern is more, I see this more often with fecal incontinence. And they possibly might be able to expel the balloon. And so this focus is going to be more on strengthening the pelvic floor. So progression is really important with all physical therapy where we're doing muscle re-education. So we're going to start with lying down. When they're able to relax and hold lying down, then we're going to progress to sitting, because we're looking at what happens when they're on a toilet, right? So we need to know what is going on when they sit. We're going to teach the mechanics of defecation, which I'm going to talk about in a second. Really important piece. Functional breathing if they need it, and then relaxation training if the patient that needs a special, training in just how to relax their whole body. So this mechanics of defecation, this is a little figure on the right, is really helpful for patients. When I show them this is what I want you to look like when you're sitting on the toilet. This piece comes in once I've got some coordination of the muscles, but it is not towards the end of treatment. It's more towards the beginning. We're going to make sure that there's no breath holding, that their jaw and mouth position is relaxed. The angle of the hips is important, right? For that angle for the rectum. We want their feet on the floor or a squatty potty. Most of the time using the squatty potty. The spine position in neutral. We do not want them slumped while this is not going to help with any of their abdominal function. Their waist. So what we want to be going on is that once their jaw muscles are relaxed, they can lengthen their abdominals while they contract them. And so they're making their waist wider. They're creating tension in their belly. We call it belly big, belly hard. And then they're pushing, then they're doing that bearing down and relaxing their pelvic floor. We want to make sure that they do not hold their breath while they bear down. So we're making them make a sound or like they're blowing out candles. And we put all of that together. It can make a huge difference moving forward with the amount of straining and the amount of incomplete bowel movements. So the next piece, if they need it, is going to be functional breathing. And that's going to be for the people who are having a really hard time coordinating their abdominals, or they cannot relax the pelvic floor. And we're looking at inspiration and expiration, what's going on with their rib cage. We wanted them to be able to inspire in about 3 seconds and expire and exhale in about 4 seconds. And we want to see their chest moving. We also want to see their abdomen moving. We want a coordinated effort there. And if we don't see that, we can work on that with muscle training. And also sometimes, like I said, we need to work on the mobility of their rib cage. And then once we've gotten these pieces together and they're making good progress, we want them to be able to contract, relax, and lengthen in sitting. So we can check that even without the biofeedback. You can check that just by palpation, by external palpation in sitting. Once we got that down, then we're going to have them initially expel the sensor. If we're using a rectal sensor, most of the time we do use an internal rectal sensor and just put them on a bedside commode and give them a minute, just like it's a balloon expulsion test, except it's not a balloon yet. And if they can expel that sensor, which is pretty small, then we go on to the balloon. Obviously, we're not doing balloon training with somebody who doesn't have that problem with their dyssynergic defecation, but the patients who do. And so when we start working with the balloon training, we recommend starting at about 20 milliliters and then progressing up to 50. and use warm water is better than air, but that sort of depends on your location. If you have a treatment room that has a sink, etc. And this slide was specifically for physical therapists. So this is the catheter we use, which is the exact same catheter that is used in the ARM. And occasionally I've forgotten to tell the patients to bring a condom to put over the catheter, and then we can't, we have to be able to use it multiple times. So that little star is on there because I've done that more than once and then I can't go forward. Okay, so that's the next piece, and that is sort of the final piece, hopefully getting to the point where they can expel that balloon, and then we're good. But sometimes the rectal sensitivity training is another piece, especially with the incomplete bowel movements. So there's a protocol for that. And with hypersensitivity, we're going to work on inserting that balloon and then gradually inflating it and then repeating that. These are the specifics here. I personally see more hypersensitivity than hyposensitivity, but this protocol comes from a presentation at Duke a few years ago, and we use it successfully. I was surprised at how quickly I saw changes with this, and it's very helpful for the patients who need it. And so this is just a little put together some things that sort of pearls of wisdom that really make a difference with getting to goals and getting to a full coordination of their pelvic floor. So there's connections between intentional thought and then what they physically sense is really the first piece. So that's why we use the visual biofeedback, is so when they think, contract my pelvic floor, they can see it on the screen. I can tell them that's it, you've got it. And then they can sense what that feels like. And then they go home and they practice. Once they get that feeling that goes along with seeing the right thing, that's a first big connection that's important. Then the next one is for them to understand that we are not weightlifting the pelvic floor. What we are doing is teaching them a skill. So this concept actually I'm stealing from Howard Glazer, who did a lot of the initial research with pelvic floor training, not for dyssynergic defecation. Actually, his patient group was mostly vulvodynia, but he talks about it being like you're teaching them to play tennis or golf. So it's the coordination. And obviously, if you practice enough tennis, you practice enough golf, you don't have to think about it so much when you swing. So we're intentionally practicing what they need to do with their pelvic floor so it becomes automatic. But it only becomes automatic if you practice long enough. And then practice. This is not something that I can tell you what to do and then you don't do, what you practice at home and you come back 2 weeks and nothing's changed. So research has shown that you change the pelvic floor, you need 30 to 80 reps a day to get any change in function. So I make sure I tell them all that. And then the coordination piece, that we have diaphragms in the body. I mean, you can argue about how many, but we know for sure there's a pelvic diaphragm, there's a respiratory diaphragm, and then the diaphragm, your larynx muscles are also diaphragm. And those diaphragms need to work together in a coordinated effort to push everything down and out. So understanding that pressure concept and understanding that that's what we're trying to get coordinated helps a lot, I think, in moving forward with reaching goals. Let's see, I'm trying not to go too fast here. So the piece about ICD-10 and CPT codes. Now I'm talking from my world, which is the rehab world, but the two most common ICD-10 codes we're using for physical therapy, this is not the diagnosis that is coming from the physician or the PA. This is the diagnosis for why do they need physical therapy. And it is pelvic floor weakness, which is M62.58. And then levator spasm is basically the terminology, but we're talking about a pelvic floor that either won't relax or a pelvic floor that is shortened up and has trigger points and cannot relax. And that number is M62.838. And then the CPT codes we use for treatment are the same ones we use for everything, whether you have a painful shoulder or you have a dysfunctional pelvic floor. So neuromuscular re-ed is all the part we're doing with most of the EMG biofeedback. So anything to do with posture, breathing, retraining muscles as far as being able to relax, being able to contract is neuromuscular re-ed, and that's 971 97112. And then therapeutic exercise, obviously, is exercise. That's a little different than neuromuscular re-ed. Might be more of the, if we're trying to get, for instance, their rib cage loosened up. And then therapeutic activity is when we do training about what to do at home, for instance, with fiber and water. That would be therapeutic activity, or self-care, depending on what you're doing. And then manual therapy is going to come into play when we're trying to work on a pelvic floor that has trigger points or literally has to be stretched. And manual therapy sometimes for improving the diaphragm function. And the other components that aren't necessarily having to do with muscle retraining is about diary. Some of our patients aren't great historians. They aren't great at giving us objective information about what goes on at home. So sometimes having a diary to find out how often are you really having incontinence, how often are you really having incomplete bowel movements and straining, a fiber diary if we're having that diet problem, and then time toileting is going to come into play with people who have a lack of urgency, a lack of sensation, I should say urge sensation, and need to have timing to try to coordinate their bowel function with regularity. Also, this is for the patients that sit on the toilet for 40 minutes as well. And I hope I didn't do that too fast. So I was trying to keep this all within our time. So thank you so much. And, questions, and let me know anything that I perhaps didn't cover for you.
Well, thank you very much, Teresa. That was fabulous. I wrote down about 3 or 4 different things. I was actually texting Nitin in the middle of it to see if he actually heard of something too. So definitely learned a lot of pearls of wisdoms during your presentation. So Nitin and I will go back and forth on the questions, and and we probably have a few for you also. Then I have one at the very end for future Teresas out there getting into this particular field, because it's very, very important. More and more people are experiencing these type of issues. Nitin, you want to ask the first question? Sure.
Yeah. So the first one we have is, do you use TENS or IFES? I don't know if you're supposed to pronounce that abbreviation or not. If so, for what diagnosis, at what frequency, and how many sessions?
Okay. So for this particular patient group, I don't use interferential current. That's not really I'm not really set up for that right now. So I would say no on that, but it makes sense. You might want to use that for pain. E-stim I'm most often using for urgency. If with fecal urgency, it can be helpful. And then we're setting that. I'm using the internal sensor E-stim. So it's already kind of set up on my Prometheus unit. I don't know what unit this person might be using, but with Prometheus, it's set up. And so for urgency, it's the 12.5 hertz. And then you're setting it up where there's on for 5 seconds. I think there's some choices there, but I usually do on for 5 seconds and off for 5 seconds. And then you're doing that for 15 minutes. And then you're seeing if you get better relaxation with that. And if you do, then you can set them up with a home unit. Occasionally, not a lot of times, but sometimes there's the patients that everything you can think of to do, you cannot get them to contract their pelvic floor. And then I use the E-stim for that. And that is going to be at 50 hertz. So this is more a functional E-stim where they are contracting while they feel the E-stim. Once again, that's set up for in the clinic for 15 minutes at a time. And then if you're getting some good results from that, you get a home unit. So hopefully that answered that.
We have another question. This is sounds like dyssynergia types are really important for the patient evaluation. Should providers be reading ARM studies with that in mind? What are your thoughts?
My thoughts, if you can get that information, I found it really helpful. I think I first started reading the results, and I had to learn how to read them. I had to learn how to understand them. And then when the types started popping up, that's when I was like, I got to do some research because I don't have these in my head. And then when I looked at them and I read through, I thought, oh, this makes so much sense. This helps me to understand the big picture better. So if possible, it's really helpful to get that information. You can get where you want to go without it, but it's nice. It's very nice to have.
Next question we have is from someone who works in pediatrics. So I work with pediatrics and don't do internal work. Do you use internal with kids?
No, absolutely not. I did not address, this was not really the pediatric population that I was really addressing with this presentation. No, never. But I am using the external. So we're just using, and I use external for adults as well, depending on the situation. So I'm just using the external electrodes, but same sort of techniques.
All right, Teresa, can you describe practically how you do sensory training for rectal hyposensitivity in terms of what are you asking the patient to sense?
So what we're trying to do is improve the sensitivity, right? So we're starting off with, so their first sensation is going to be higher than normal, right? So we are starting off where they feel it and then gradually deflating that balloon and then repeating that. I think the specifics are in one of the slides, but repeating that and so they become more and more sensitive with the trials. So you can get changes. And so once you completely deflate it and then start over, you can see a change immediately as far as their sensitivity, and then hypersensitivity going the other way. Does that make sense?
Okay. I think so, yeah.
Yeah.
I might skip to the end here, just on the same topic, or a question that's on sensory biofeedback. Any recommendations for sensory biofeedback? It says or megarectum, maybe that means of megarectum, but thoughts on sensory biofeedback in the context of megarectum?
Okay, so that's going to be the same. So I don't think I don't get as many of those as I do hypersensitivity. I think I said that already, but it's the same. Hyposensitive and mega is going to go together. So it's the same protocol you would use for hyposensitive.
Do you think resistance training additionally benefits patients with fecal incontinence along with biofeedback therapy?
You mean exercise, like working on their core and working on their glutes and that sort of thing?
I'm assuming some of that type of resistance training.
As a conjunction, yes, especially if they have poor core strength and they have poor hip strength. A lot of times you also have poor core strength, you've got glutes are weak. So I'm working on all of those along with the biofeedback with that patient. Yes.
Okay.
Another question from Dr. Moshri. Sort of an interesting question. What patient scenario is bad to send you? What would you prefer not to see?
Oh. Patients who do not want to work, don't want to do their homework. I mean, if they are coming under a sort of like they don't want to be there and they really don't, they expect to come in and I'm going to show them some things and then they'll be fine. I think that's a really difficult situation. I'm trying to think like experience. Not so much Dr. Moshri's patients, but I do sometimes see patients that haven't had maybe enough testing. Like I really want it. I was like, oh, you need an ARM. And they haven't had one yet. So that's a little bit rougher for me. And then if they have with like IBS problems, so if your Bristol stool scale is always a 6 or 7, holy cow, I'm working on your pelvic floor, but this is an issue if it's always a 6 or 7. So sometimes it's the order of things and I'm not like gonna affect necessarily what's going on with the Bristol stool scale. And I'm working uphill. Does that make sense?
Yeah, it sure does.
Yeah.
I think just to take a tangent, I think it's striking how different certain physical therapists are in terms of how they emphasize manometry. Like it sounds like you really value the results and almost to the point of needing it before you can proceed. Versus, I've been in certain practice settings where physical therapists really don't look at the manometry at all and prefer to go by their own assessment. Any thoughts on whether this is kind of an individualized preference truly, or if it ought to be really part of any approach to pelvic floor rehabilitation to look at these objective data?
I think I did not initially understand what I was missing because, okay, so I'm going to say I'm not, obviously not young. So the ARM wasn't anything that I understood fully or appreciated until Dr. Mosheri and Jason Baker were near me. Before that, I only saw the results when patients went, so I'm in Charlotte, when patients went to Chapel Hill and got results. And sometimes I had a hard time getting those results. And so I didn't understand what I was missing. So I would say it's really important if you can get a hold of it and it's helpful for the big picture, really helpful for the big picture, especially to understand what you're seeing, if that coordination piece and then the rectal sensitivity. I mean, there's no other way we don't know what their rectal sensitivity is. Yeah. I can't tell that at all. So that piece, and it can be that last piece that they really need. I mean, if you're really hypersensitive, you're going to have a sense that you need to have bowel movement all the time. And so you're going to have these incomplete bowel movements because you keep going when you shouldn't. So if you can change that for sensitivity, it's gonna move them forward.
That's a good point.
Yeah, and I totally agree with you, Teresa. And then I just think also it's a continuity of care. And I believe with these folks, the results, you have a better chance to have positive results when it's a multidisciplinary approach when throughout the whole process. So there's a question. Sometimes it's hard to teach kids how to do Kegels. Any tips in that?
So I would say the kids love the visual biofeedback. Now I have the basic, the 1500 of Prometheus, which doesn't have the kid-friendly stuff. Now the highest level biofeedback that has a lot of kid-friendly things, I mean, that's fantastic. I do okay without it. But when they can see that when they do the right thing, they can see it on the screen. It's like light bulbs go off and like you're talking to them and they're already doing their thing on the biofeedback. They don't even listen to me anymore. They're making it go up and go down and go up and go down. And they're so much faster than adults as far as once they've got it, they take off. So I would say the visual biofeedback is probably the biggest piece. And also I always make sure that the parent is obviously they're in the room, but the parent can see what I see. So when I do my initial exam with the kids and I'm looking at their pelvic floor and asking them, now that first visit, a lot of times you get like nothing with the kid, like nothing, but you can show the parent, this is what I'm looking for. I want you to see this, when you look at their pelvic floor, this is what I want you to see. And so if you coordinate what the parent is doing with the child at home, along with what you're doing, it helps I think that helps a lot. And then of course they have to practice with their child. So a common issue is I'll say, how did your exercises go? And the child is like, we'll say 7 or 8. And the parent goes, so Tommy, how'd the exercises go? Which tells me right there, mom was not with Tommy when they did the exercises. So that if you can get coordination with the parent and the child to do them together, that helps a lot too.
A question from Dr. Jaffin. Do you find that if a patient has a normal balloon expulsion time with subtypes of defecatory dyssynergia 1 or 3 on manometry, that the number of treatments in physical therapy is less than those with an abnormal balloon expulsion time? So do you find that there's any sort of, I guess to rephrase that a little bit, predictive quality with regard to the course of therapy based on the results of a balloon expulsion time?
Yes. So like the first patient so this patient is in my mind, how you have patients and you like learn a lot from them because you didn't know what you didn't know. So another therapist had seen her, very good therapist, excellent at what she does. And then she got sent to me and I didn't have that balloon expulsion information. And I did my exam and I thought, well, she's fine. She can lengthen her pelvic floor. She's fine. And then I said, I don't understand why she's here. I don't understand. So then I got the balloon expulsion information and I thought, oh, she's not fine. She can't expel the balloon. So when I added that piece in, then I understood more what to do with her. And it took a lot more time than I would have expected for her to get better because of that. So in general, when it kind of depends on like type 1, they're like, I mean, it's rarely is that their balloon expulsion okay with type 1. But type 3, if they can, then it goes faster. If they pass that test, it definitely goes faster. And it's a little less confusing. I know I'm going to have to do balloon training, basically.
Got another question for you. Do you have any experience with Kegel toner devices for patients with fecal incontinence? If so, are there any that you recommend? Probably just
So are we talking about it's the e-stem that's like specifically for fecal incontinence? Is this what they mean?
I'm assuming. I'm not sure.
Okay,
I've not
so
heard of Kegel toners.
I know about them, but I have not used them.
Okay. That's fair. I have a question for you because I have not heard of this. Well, the LaCroix scale you mentioned,
Lecoq.
is that a qualitative or is that a quantitative scale?
That's quantitative.
Okay.
So it's like there's the 4 things that we all look at. So it doesn't matter whether I'm seeing this patient or I'm seeing, a urinary incontinence, a female urinary incontinence kind of. So yeah, it's 4 numbers, and the norms, are 10, 10, 5, 5, 5, 10, 5. I'm going to get the order wrong, but anyway, those are reproducible, inter-rater reliability, etc. Yeah.
Excellent. Well,
Also on the subject of protocols, I think to my mind, probably naively, because I don't know the literature as well as you do, I feel like biofeedback is something that we talk about a lot in the MD side of things because that's where data is. It's been studied, and I've been told in the past that like everything else is still useful, but probably harder to standardize and therefore harder to study. But I guess when we talk about protocols, that makes me think of a research opportunity. Do you have thoughts on whether there's movement in that direction, or what other barriers might be to shoring some of these maneuvers and protocols up with data?
So I work in fortunately in an area where we have a fairly large team of physical therapists, and not everybody is as much of a fan of biofeedback as I am. And so I would love to do a study that's sort of like physical therapists who use a lot of biofeedback and physical therapists who don't, and see if the results are different. Because some therapists say, I get the results you get, and I don't use much of it at all. I use palpation, I use examination, and I don't have to use the electrodes, and I still get my goals achieved. So I think there's a bit of a shift, maybe in a direction I don't like, a little away from it in my area. Now, I'm not sure nationally if that's the case or not, but I think it would be great it would be great if we could.
Yeah, and Teresa, we're near our end of our time point. I just want to ask you one question for Nitin, close this out. But if you had to give some pearls of wisdom to someone who wants to start practicing in physical therapy for pelvic floor, what pearls of wisdom would you give he or she?
Like to take good courses and then practice a lot. Be in a situation where you've got mentors to help you, and then make sure you see enough patients that you get lots of practice and lots of different diagnoses, and take a lot of courses. It's a great field. It's extremely rewarding, and it's never boring. That's what I like about it most.
That should be your slogan. That's a good one. All right. Well, Nitin's going to close us out. We're at our time. And thank you for everything.
Thank you. I appreciate it.
Yeah, thank you so much, Teresa. This was great. That was a nice note to end on. I want to thank my co-moderator, Jason, and the ANMS leadership and administrative team. I want to thank the audience for sticking this out this evening and for asking such great questions. And just to let you know that the conversation need not stop here. Doc Matters is our online online community for for asking questions of all kinds at all hours. So feel free to continue the conversation there. But for now, thank you again to Teresa, and wishing you all a good night.
Thank you so much.
Bye, guys.